All right, I think we might kick off. We are still letting people in, but just while we do the brief introductions and to keep us on time. So welcome everyone to tonight's webinar. We're talking about changes to the chronic disease management framework and the implications for allied health professionals. My name is Philip Herman. I'm a Senior Policy Advisor at Allied Health Professions Australia. And I'm pleased to be joined by the Department of Health and Services Australia. Now, the structure for tonight's webinar will be that we'll have presentations first from the Department of Health and then Services Australia, and then we'll move over to the Q&A session. We've got a Q&A tab at the top, hopefully on your screen, that you should be able to enter any questions. We'll be seeing those throughout the webinar, so put those in any time and we'll work our way through those at the end. If there are questions similar to what you'd like to ask, feel free to use the upvote button so that we can see which ones I guess are particularly popular. Now, before I go any further, I'd like to begin by acknowledging the traditional owners of the lands on which we all live and work. For myself, I'm in Melbourne, so that's the Wurundjeri people of the Kulin Nation. I'd like to acknowledge elders past, present and emerging, and any Aboriginal and Torres Strait Islander people participating today. Now, I wanted to just provide a very brief introduction to Allied Health Professions Australia for those that don't know us. So Allied Health Professions Australia is the Commonwealth-funded national peak association for all allied health professions. So that includes your individual allied health professional associations like the Australian Psychological Society, Podiatry Australia, and so on and so forth. This webinar is being presented on their behalf. Now, I will introduce now the speakers that we've got for tonight. So we're joined by Imogen Colton and Alex Nicro from the Department of Health in the General Practice and Primary Care sections. They'll speak first. And we're also joined by Naomi Van Beek from the Medicare Benefits Division at Services Australia. I'll now hand over to Imogen.
Thanks very much, Philip. So as Philip said, I'm the Director of the General Practice section in the Medicare Benefits and Digital Health Division at the Department of Health, Disability and Ageing. And the reason I'm speaking first and speaking to a lot of these changes is because the primary changes that we've made to the chronic conditions management framework are actually changes that affect GPs. So I'm going to talk through an overview of I'm going to talk through first a little bit of background to the changes that have been made. I'll go through a quick summary of what the key changes are and then talk about them in more detail with a focus on those changes that directly impact on allied health providers. Then I'm going to hand over to my colleague Alex, who will talk a little bit about the current review by the MBS Review Advisory Committee of the Allied Health Services. And then I'm going to hand over to Naomi to talk about the online MBS item checker and a few other things that you can do on AHPs. So before I kick off, I just wanted to go through a few key points about the changes that came into effect on the 1st of July. You're probably aware that the trigger for patients to be able to access allied health services through the chronic conditions management framework is that GPs have put in place certain planning arrangements with their patients, and that is a prerequisite to accessing services. Those planning arrangements for GPs are the real focus of the changes we've made, and they are quite extensive. There are a number, however, while the focus is GPs, there are a number of consequential changes that impact on allied health service providers. But the first thing I want to emphasise is that there are absolutely no change to the numbers you use to provide allied health services under the MBS, and there's no change to the scope of those services that you provide. The changes are much more around the administrative arrangements for those items. So the changes that affect allied health providers directly are that the type of the plan that the patients will have moving forward has changed. So we no longer have team care arrangements in the form we used to have them. The arrangements around referrals have changed, And there is a requirement for patients to have their plans reviewed periodically for ongoing access to services. And I'll talk about all of these things in a lot more detail shortly. The other thing is that for patients that had a GP management plan and or a team care arrangement prior to these changes coming into effect on the 1st of July, we have transition arrangements so they can continue to access their allied health services and you can continue to provide them under those old plans and referrals during the transition period. So just a little bit of background to the changes. These were originally announced by the government in the 2023-24 budget. They were originally to commence on the 1st of November last year, but they were deferred until the 1st of July this year when they came into effect. We recognise these are big changes, and while we make changes to the MBS quite frequently, the last major changes to the chronic disease management items were actually in 2005. So they've been very stable for a long time, but a lot of things have changed around them. And so we needed to do some modernisation of the system. Now, they broadly implement clinical recommendations that were made by the MBS Review Task Force. So in case you're not aware, the MBS Review Task Force was a review of all items on the MBS that ran from 2015 to 2020. It was a clinician-led review. It made about 1,400 recommendations across the MBS. And the changes that we're talking about here to chronic conditions management relate to one of those recommendations. And their key focus with the chronic disease management, as they were items, was to streamline and modernise those arrangements. They wanted to see GPs doing more reviews of their patients, and they wanted to put an emphasis for continuity of care for those patients, particularly in terms of their GP that manages their overall health. And so that's the background to where these recommendations have come from. Once government made the decision to make these changes, we did have support from an implementation liaison group, which was primarily a clinical group. As I said, the majority of the changes affect GPs, so they were mostly medical groups, but there was also some allied health representation on that group through AHPA. And we also had a communications working group, which involved a number of the allied health peak bodies as well. So just to recap on what the arrangements used to look like. So before July, we had the MBS chronic disease management framework. It was designed for patients that had a chronic condition that would benefit from a structured approach to their care. So patients were eligible if they have at least one condition that has been or is likely to be present for at least 6 months or is a terminal condition. In terms of the GP management of those patients, we had two types of plans that were the most common plans. There was a GP management plan, which was between the GP and the patient, and it set out the patient's, like what the patient's conditions were, the current state of their health, their treatment goals, and it was very much about that overarching framework for how the GP and the patient proposed to manage their chronic condition. So that was available to any patient that had a chronic condition that would be lasting for at least 6 months. If that patient would benefit from multidisciplinary care, they could also have a team care arrangement. And that was the plan that as an allied health provider, you're probably more familiar with. There had to be 2 collaborating providers, and it set out the sort of treatments and services that the patient would require from the multidisciplinary care team. There is also a thing called a multidisciplinary care plan, which is what we had for patients in residential aged care. And that provides the same access to allied health services as the GPMP and the TCA did. But it was quite a complex system with multiple types of plans and quite a complex web of services that patients could access. So that patients that had the GP management plan or a team care arrangement or a multidisciplinary care plan could access a number of services, 5 per calendar year, that were provided on behalf of the GP by a practice nurse or an Aboriginal and Torres Strait Islander health practitioner. Patients that had a GPMP or a multidisciplinary care plan and had type 2 diabetes could have an assessment for their suitability for certain group allied health services, and if they were suitable, up to 8 group services per calendar year. And then if the patient had a GPMP and a TCA or a multidisciplinary care plan, they could access the individual allied health services under chronic conditions management. So it was a fairly complex matrix, I guess, of services and conditions and plans for everybody to navigate. And so that's kind of the background to the changes that were made. So going forward, what has changed and what has not changed? I might start off with what has not changed, because there's quite a lot of things that we haven't changed at all. The first is which patients are eligible. So patients are still eligible to receive services under this framework if they have a condition that has been or is likely to be present for 6 months or is terminal. The providers that can provide these services have not changed. So for doctors, that is general practitioners and prescribed medical practitioners, and then the allied health providers who can provide services either individually or as group services have not changed. I might just pause there for a second and talk about GPs and prescribed medical practitioners, because we have had a couple of questions come up about prescribed medical practitioners. From the perspective of patients and allied health providers, you probably won't see any difference between a plan that comes from a GP or a prescribed medical practitioner. The difference between them relates to their registrations. They're slightly different categories of doctors. Their items are identical. They just bill a different MBS item number. You would have seen almost certainly some plans from prescribed medical practitioners in the past. We've always had these two types of practitioners, or for a long time, I should say, have had these 2 types of practitioners able to provide these services. We are just drawing our communications together a bit more, so we have a single set of communications that they covers both types of doctors, given they have identical items. So in terms of the allied health services that follow on from the plans that they put in place, there is absolutely no difference. The modes of services, so face-to-face and telehealth services, have not changed. For GPs, we still have items for preparing a plan and reviewing a plan, and I'll talk a little bit about that more in a second. GPs also have limitations on how frequently they can provide services. That has not changed, but again, I'll talk about that in a minute. The number of allied health services that can be provided under a plan has not changed, and there are no changes to those multidisciplinary care plans for patients in residential aged care. What has changed is, I guess, the primary change, and that everything else flows from, is that the GP management plan and the team care arrangement have been replaced with a single GP chronic condition management plan. I'm going to talk about that a little bit more in a minute, but we have gone from that structure of having 2 separate plans to having a single plan for the patient that covers everything. From the GP perspective, these items have always been should have always been provided by the patient's usual GP, but we have strengthened some of those requirements, including in certain circumstances linking these to their My Medicare registration. But again, that only affects the GP items. It doesn't affect allied health services. I did mention one of the priorities of the MBS continuous review was to have, the MBS review task force was to encourage more reviews of the plans that patients have. So we have always had items in place for GPs to prepare reviews, prepare plans and review plans. But what we saw a lot of was patients were having plans put in place, and then a year later they might have a new plan put in place. So the clinical outcome we're looking for here is for patients to have their plans reviewed more regularly by the GP, and for those plans to develop with the patient as their condition either stabilises or progresses or whatever the circumstances happen to be. The referral processes to allied health services have been changed. And I'll talk about that in a lot more detail in a minute. And as I already flagged, we have a 2-year transition period for existing patients. So just to go into the changes in a bit more detail, just to explain the plan that GPs put in place a little bit. So the GP chronic condition management plan is a plan that is between the medical practitioner, so the GP, and the patient. It is intended to be comprehensive, so if the patient has multiple chronic conditions, they still have a single plan. They don't have a separate plan for managing their diabetes and their cardiovascular disease, for example. They have all their information in one place. And the plan is intended to document the patient's condition and their treatment goals, which I think is a really important aspect that has always been in the plan, but we are probably focusing on a little bit more in this iteration of the plan. The actions to be taken, including the actions to be taken by the patient. Obviously, that's really important for managing a lot of chronic conditions. For a lot of patients, there will be lifestyle changes that may need to be made or put in place. So this is where that is all documented and agreed. It also documents the treatment and the services they're likely to need, and the patient's consent to the plan, and where relevant, sharing that plan with other providers. So then we come to the bit that is similar to the team care arrangement, but is a bit different. So if multidisciplinary care is required, the plan needs to outline the services the patient will be referred to and the purpose of those services. So the number and the nature of the services that the patient might be referred to are not limited to the 5 allied health services that most patients can access under the plans. It is intended to be comprehensive. So it can also include services that are not funded through the MBS, be they through community health or other services. So, if the patient needs to agrees that they want to increase their exercise, for example, this could document that the patient is going to join a walking group or go with their family member who goes to park run and walk the park run or something like that. It can be anything. It can be allied health services. It could also be specialist medical services, depending on what the requirements of the patient are. A key thing with the plans is because we have merged that kind of concept of the GP management plan and the team care arrangement into a single plan, the requirement for there to be 2 collaborating providers, which is what we used to have in the team care arrangement, has been removed. As has the requirement for those collaborating providers, which usually was allied health providers, to agree to the plan has been removed. That doesn't mean that cooperation and collaboration between the GP and other members of the team are not important. They absolutely are. But that signing of the plan and agreeing and sending it back to the GP is not a requirement anymore. The other thing that has changed, as I said, is we are looking to really encourage reviews of the plan, and that is something that has always been possible. So we have changed the financial arrangements in the GP items to encourage those reviews to be done. There are requirements for allied health providers to report back to the GP at certain intervals when they're providing services. And those reports from the allied health providers and other members of the multidisciplinary team are really important in helping GPs review patients' progress against the plans. Patients going forward will also need to have had either a plan prepared or reviewed in the previous 18 months to continue to access allied health services. We don't think this is particularly onerous on patients because we know they were already going back to the GPs regularly to get new referrals every 12 months or so. So this is just an additional check, and it goes to that continuity of care issue I spoke about as a desirable outcome for the MBS review. So the other big change for allied health is in the referral arrangements. So for the referrals, we have actually brought the rules for referrals for allied health services in line with the referral rules for other services under the MBS, particularly those for referring to medical specialists. And there's a couple of parts to that. We have removed the referral form as it previously stood for allied health, and that means that GPs will be transitioning to writing referral letters as they do for other referrals. But it also means that the rules around specialist referrals are also mirrored for allied health. So, for example, there are now some rules and guidance around what happens, for example, if a referral is lost, and clearer guidance on things like the contents of referrals and signing referrals. Because we are moving away from that form to letters, there will be more clinical information in referrals than there was previously. And where the patient has consented, you'll also receive relevant parts of the plan. And that will be in line with the types of clinical information that is provided to specialist doctors as well when they get their referrals. So about why the patient is being referred and their medical history that has led them there. Referrals do not need to name the specific allied health provider that the patient is being referred to, but they will specify the service that the patient is being referred to, or they must specify the service. So, for example, you can't provide physiotherapy services under a referral for podiatry, but the patient could take their physiotherapy referral to their preferred physiotherapist. So this is empowering patients a bit more. Often patients will consult with their GP about who they recommend or who's in the area. But if the patient has a preferred allied health provider that they know, or that for some other reason they would like to go to, they can take their referral to that provider. Referrals are also valid for the period of time specified on the referral. If no time is specified, they'll be valid for 18 months from the date of the first service under that referral. So again, that links in with the 18-month review period that GPs have. And counting the time from the first service under the referral is also in line with other referrals under the MBS, including those for medical specialists. We have not changed the allied health reporting requirements. So I've got an extract here that is from the regulatory requirements that are set out in the allied health determination that says eligible provider, that's the allied health provider, will give a written report to the medical practitioner if the service is the first service under the referral, the last service under the referral, or if the service involves matters that the referring medical practitioner would reasonably expect to be informed of. So those are the requirements that have stood for a long time, and we haven't changed them, and they continue to apply. And those reports back, as I said, are really important to the GPs in reviewing the patient's progress. So I guess just to comment on why those referrals have changed, We had some feedback from allied health providers that they would appreciate more clinical information coming through in referrals. We are looking wherever possible to have consistent rules across the MBS. So this seemed like a good opportunity to align some of those broader rules that sit around referrals for allied health providers with the referrals that apply to other types of or other types of services. And as I mentioned, patient choice. So patients can take their referral to their preferred provider. And Naomi's going to talk a lot more about this, but we have had a number of questions on how, under the new arrangements, providers know how many services are available. So firstly, to be eligible for the allied health service, the service should be identified in the patient's plan. It is a requirement of the allied health items that the service is consistent with the plan. You should ask the patient whether they'd like to use their Medicare benefits for the service. Providers can, if they say yes, providers can check eligibility for an allied health service using AHPs, and Naomi's going to go through that. And patients can also track their services under their various care plans, including the chronic condition management plan, through their Medicare online app. Just lastly, I wanted to cover off on the transition arrangements for the existing patients. So it was really important in making these changes that patients that had their GP management plan and TCA in place prior to the changes could continue to access their services. And they can until the 1st of July 2027. So there is no need for patients to go back urgently to get a new plan from their GP. The next time they go back for a review, their GP can put the new type of plan in place, but they can continue to access services for that period. Similarly, any referrals written prior to the 1st of July remain valid until all services under those referrals are provided. The new requirements only apply to referrals written after the 1st of July. But from the 1st of July 2027, all patients will need to have a GP chronic condition management plan to continue to access services. I'm now going to hand over to my colleague Alex to talk about the current review we have of the allied health chronic condition management services.
Thanks, Imogen, and hi everyone. So my name's Alex, and I look after the primary care MBS services other than GP services. So we look after nurse practitioners, participating midwives, allied health services, and Aboriginal and Torres Strait Islander primary healthcare services. Thanks for the opportunity to speak tonight. Some of you may be aware that we're actually looking at the allied health services under the chronic condition management item suite. This is something that we thought was important to look at, noting that these services have been on the MBS for quite some time, but other than the addition of group services in 2007 and some case conferencing items in 2021, they've remained largely unchanged. So we thought it was high time to have a look at these and work out whether they can be improved. And that's very much what we're aiming to do, is to work out whether these services are adequately supporting patients with chronic conditions and what refinements we might be able to make to them to improve them. So there's essentially 4 key considerations that we're looking into. The first and most important, of course, is the number of services per patient per calendar year. As you would be aware, at the moment, patients are eligible for 5 allied health services per patient per calendar year. And recently, Aboriginal and Torres Strait Islander patients were eligible for 10. And that's a merging of the chronic condition management items and the health assessment follow-up items. So what we're really trying to look at there is whether that 5 is appropriate, appropriate, and whether we should be looking to change that. And certainly a lot of the feedback we hear is that 5 is not appropriate for many patients. So I suspect we'll be making some recommendations around some changes there. One of the other things we're looking at, of course, is length of service too. As you would all be aware, the current MBS item requirements are for a minimum of 20 minutes. We're mindful that in many respects this might not align with the way that services are delivered. So we're going to be looking at that minimum time length and potentially also looking into time tiering as well. Another key consideration is in relation to group therapy. So at the moment, allied health group therapy services are only available to patients with type 2 diabetes, and the only allied health professionals who are able to deliver those are dietitians, exercise physiologists, and diabetes educators. So we're having a look as to whether we might be able to broaden that out, both in terms of eligible conditions and eligible providers. And then the final key consideration we're looking into is, do we have the right mix of eligible allied health professionals, and should we be looking to expand that further? So to help the MBS Review Advisory Committee, we've pulled together a working group, and that is largely comprised of allied health professionals, along with Aboriginal and Torres Strait Islander primary healthcare professionals, some general practitioners and consumers as well. So where are we at? What we're wanting to do is ensure that we've got some research to inform the working group and the committee proper. So what we've done at the moment is we're working with the Sachs Institute on a rapid review of the evidence base, and we're also concurrently undertaking some qualitative research of peak provider and patient views. And in particular with the qualitative research, we've now consulted with all of the peak bodies for the eligible allied health professions, and we've undertaken a number of online forums for both patients and providers to make sure that we can get some direct feedback from the people who are using these items and their experiences as well. So once we pull these two research outputs together, we're going to be presenting them to the working group to inform their recommendations. We're sort of mid to 2/3 of the way through the research at the moment, but we're anticipating that we'll be able to pull the working groups back together in late November, early December to continue those discussions. It's always a little bit hard to provide concrete timeframes, but we're very much hoping that we will have draft recommendations in the first half of next year. And of course, as with all reviews, we will then be undertaking targeted and public consultation on those draft recommendations before finalising them and then submitting to government. It's important to remember, of course, that ultimately any changes to the item group will be a matter for government and need to be undertaken through a budget process, but we'll certainly be working to pull these together in a rigorous manner and get these to government next year.
Give a little bit of an overview that Naomi was going to present. So the item checker essentially has the capability to check whether the claim you're about to submit may be paid or not. It's not a full assessment of your patient's claim, but it's meant to be a really good indication of eligibility to support you to have that financial consent discussion with your patient before going ahead with the service today. It's recommended that you check the item eligibility as close to the appointment time as possible, as checking it a week or 2 weeks before the appointment time could allow for other allied health claims to be submitted, which may affect your patient's eligibility for a service, i.e. they've had other claims paid and therefore that 5 service limit in a calendar year has been reached. The item checker cannot check my Medicare eligibility component of claims. This is more for GP claims. It also cannot check in-hospital service items, which again doesn't really impact the allied health items. It's also important to note that it is unable to see what other claims have been submitted but not yet assessed by Services Australia. So it's again intended as a guide only. We are aware that many health professionals would like to see how many treatment allied health items a patient has had left on their plan. However, it's not available in HPOS, as this would impact the patient's privacy if you were able to access another provider's services. However, patients do have the ability to check their claiming history on their Medicare Online account. This now includes a My Care Plan history section. Customers can select the relevant period through the drop-down menu and can filter and view by care plan type. For example, they can see what they have available on their mental health care plans as well as their chronic condition management plans. They can also download a summary of these services in PDF format. Please feel free to recommend these available services to your patients, and it can assist to have those conversations. There are plenty of resources available on the different tools in HPOS on our Health Professional Education Resources website, and we can share links to those with the webinar outpack. I'll just check and see if I can quickly screen share that simulation that Naomi was going to share with you. Let me just, it's telling me I'm not going to be able to share. I may not have the right permissions, as I wasn't going to be presenting today. But it is a simulation that walks you through how to log into HPOS and how to use the MBS item checker tool, including how to select the appropriate chronic condition management allied health services or health assessment allied health services or mental health.
Thank you, Liz. And I have posted that in the Q&A section now. So for anyone participating today, you should be able to access that link. I encourage you to look after this session. Apologies that hasn't worked. But I might suggest, Liz, unless you have anything else you wanted to speak to, that we start to go through some of the Q&A questions.
Yep, now let's go to Q&A.
Is that okay? Excellent. So I might actually start with referrals. And so a couple of people have noted that they are getting referrals now in the body of an email. So what they're asking effectively are, what are the requirements for a referral? There's also a follow-up comment that some have noted that there's no reference to the GP management chronic disease plan in the referral. So it's more of a letter as such that doesn't specifically reference the program. So again, I guess there's sort of a couple of questions just about what are the requirements for that to be a valid referral?
Yeah. So Philip, there are a few requirements. The other thing now you've mentioned that I might send through to you after this presentation, probably tomorrow, that you can share with members, is we have a number of explanatory notes on MBS Online, and in particular we have one specifically about the referrals for allied health as they stand now. And I think that has hopefully some really helpful information about and spells out exactly what the requirements are. So the first thing is, yes, electronic referrals and electronic signature of referrals are allowed. That is okay. So yes, if you are getting those electronically, that should be fine. In terms of what else is required, the referral should have the name and usually the provider number, or at least the address of the referring practitioner. It should be signed. It should have the purpose of the referral specified, and it should be dated. I think they are the key requirements.
So would a signature block count as that signature if it's just effectively a typed name but still has identifiable information about that referring practitioner?
It should have a signature of some kind. So yeah, we can get you some more detail around that, definitely.
Thank you.
As a follow-up. And sorry, what was the second part of the question?
Was if it didn't specifically reference the program, so effectively, what the referral. So if it was just a referral, for example, for a physiotherapy service, and didn't specify that it was under the chronic disease management program, is that still okay, given that is the only basis on which the referral could be made for that profession, if that sort of makes sense?
So So if the patient has been referred under the chronic condition management arrangements, I would usually expect that there would be some discussion in the referral, or while it doesn't specify, the reason is they're being referred for their chronic condition. So you would expect there to be a reference to a chronic condition at least, if it doesn't explicitly say the plan. You would also expect, unless the patient has not given permission, that the plan or relevant parts of the plan would be provided as well, as that referral. And then if you're not completely sure, you should have that plan, because you need to know that the service you're providing is consistent with the plan, but you can also check the patient's eligibility, as Liz just explained as well.
Thank you. I guess I had a question that's not directly related to a question from one of our participants, but sort of a related question. It feels to me that we're going through a transition. General practitioners are obviously still learning as well.
Yeah.
Is there a point at which the department's perhaps gathering feedback, or we could gather feedback about just some of the things that we're seeing perhaps that are not quite working? Because I know you're very involved in supporting GP education and making sure that that side is working.
Yeah, look, I think we are always keen to hear what is and is not working. As Alex has said, there is currently a review of the allied health services underway, which provides opportunities, but we do also, as a matter of course, do post-implementation reviews once the changes have been in place for a little while. So you're right, this is a transition period and everybody is kind of learning about the changes. But we definitely would love to hear feedback to feed into those various review processes as they happen.
Thank you. And thank you. Another clear question that came through a number of people was, I guess, the length of the referral. So there were questions about exactly when does the 18-month period start? Is that at the point of the referral, the point of the first service that's commenced?
The first service.
Okay, perfect. So if somebody got a referral in May, but the referral was in August, the 18 months starts in August. Excellent.
That's correct.
Another follow-on question was about the 5 services. Is that referral just for 5 services, or when the 12 months ticks over, does that referral then count as the next year's 5 services?
Yes. So the referrals can run for 18 months, so they can tick over the calendar year. The number of services the patient can access aligns to the calendar year. So that has always been the case as well. Referrals have been able to tick over, as have when the number of services resets.
Thank you. I've got a couple of questions around the Aboriginal and Torres Strait Islander items. So the question here is, if they present with the GP chronic condition management plan and require more than the 5 services, do they require a separate referral to access the extra service that they have as Aboriginal and Torres Strait Islander people, so the 10 services, or does that initial referral actually cover the full 10 for those patients?
I'm happy to take this one. So certainly my understanding is there's no separate requirement for an extra referral. Essentially, so once a referral is made, and whether that referral is made through the M11 item group, which is the health assessment follow-ups, or whether it's made under the chronic condition management items, that immediately allows that patient the 10 services.
Thanks very much, Alex. So I'm just going to keep firing the questions. They're coming through thick and fast, so thanks everyone. I've got another question about somebody with type 2 diabetes, and the question is whether they require separate referrals for the group items and the individual items, or is a single referral enough for somebody who's eligible to provide both of those services, such as a diabetes educator or a dietitian?
I'm happy to take this one as well. So there's no requirement for a separate referral. Essentially, if the patient is being referred, a single referral should be sufficient, bearing in mind, of course, that the initial referral for group therapy is for an assessment for group therapy, and the patient needs to be assessed as being somebody for whom group therapy would be appropriate. So while that can all be done as part of a single referral, it is important to remember that before the treatment can occur, the patient does need to be assessed as being both eligible and someone who would benefit from group therapy.
Thank you, Alex. We've had a number of, I guess, both comments and questions around reporting. So a number of people have commented that the reporting requirements, I guess, can be potentially quite onerous, particularly given the limits. To me, that's something that we're certainly discussing as part of the chronic disease management review that's happening at the moment. But for clarification's sake, Alex, you might be able to answer this one. Somebody talked about if a GP refers for 3 sessions and then somebody goes and gets the 4th and 5th sessions also referred by that general practitioner. The understanding was that both the first and the last session would have to be reported on. So you'd effectively report on session 1 and 3. But then for the re-referral, sessions 4 and 5 would also then need to be reported on because they are, again, the first and last sessions of those referrals. Is that correct? So could it mean potentially that somebody would actually have to generate 4 reports for 5 services?
I think if you're looking at it technically, yes. And so just to make sure I understand that scenario, we're talking about the same allied health provider who's had 2 subsequent referrals. Look, technically, I guess that would be the case, but at the same time, I think we could probably also expect sort of a little bit of judgment around the appropriateness and the need and the extent to which that report or how much time you'd need to take with the report, noting that you had just reported back to the GP as well. So yes, technically you need to do it on the first service, on the last service, and any time in between in which you thought that there was a need to report back to the GP. And I guess in that circumstance where you weren't expecting the subsequent 2, yes, that would sort of be what was expected. But again, we can appreciate that sort of might be a bit onerous, and these reporting requirements are certainly something that we can consider and think a bit more about once we start getting some of the feedback that we've heard about and as was alluded to by Imogen about these changes as well.
Thank you, Alex. And just for the participants, from an Allied Health Professions Australia perspective, we are noting all of the comments. A lot of the, I guess, posts are more comments than questions, and those are really useful. Some are talking about your experiences. So again, those are all things that we will collate from our end and make sure that we pass those along as that review is occurring. Sorry, just going through. A couple of people have, again, I think it speaks to the transition on the general practice side and perhaps some confusion, but can I confirm there's no connection between the Better Access plan and the chronic disease management plan? So a couple of people have commented that they've been told by their GP that they basically can't sort of double dip, if that sort of makes sense. If they've had their 10 Better Access programs, that somehow interacts with the chronic disease management items. That's not correct, is it? They are entirely separate.
Yes, certainly. They are separate plans, and the referred allied health services underneath those plans are also separate. So there is nothing that would prevent somebody receiving 10 psychology services under Better Access and then potentially receiving further under a GP chronic condition management plan, as long as the patient was eligible for both of those plans.
Fantastic. So it is possible to deliver mental health services as part of the chronic disease management items for the mental health practitioners. Is that what you were saying? Yes.
Yeah, absolutely. So there are a number of mental health workers, as it's referred to under the chronic condition management items, who are eligible to deliver those services. Just from memory, it's psychologists, occupational therapists, Aboriginal and Torres Strait Islander health workers and practitioners, and social workers as well. I'd double check that, but all of those are eligible to provide a mental health service under the chronic condition management items.
Thank you very much. We've got a couple other questions again around the referral, whether the referrer provider number needs to be provided. Again, I think you've answered that, Imogen, in terms of saying it doesn't need to be provided, but there does need to be sufficient information about who the practitioner is that's providing the referral. Have I understood that correctly?
I'll double check the exact wording of the rules, but I believe it is the provider number or the address of the practice where they're providing the service. I think in almost all instances, you would expect the provider's number to be there because most GPs have it on their letterhead.
Thank you. Another question, does a patient need to see 2 allied health professionals to be eligible for a referral for the chronic disease management program?
I can take that one, and certainly I can confirm that that's not the case. As Imogen mentioned, there is no longer a requirement for 2 collaborating providers. There was a bit of a misconception previously too, where while there did need to be 2 collaborating providers, they didn't both need to be allied health. So it might have been a GP, a practice nurse, and an allied health provider. So it's never actually been the case that they need to see more than one allied health professional. But certainly that should be even clearer now that there's certainly no need for more than one.
Wonderful, thank you. I just having a quick look through for any questions. There is a lot of overlap. Apologies also, if we don't get to everything, we will see if we can respond to a couple of the kind of more common question areas. So we will look at just getting some additional information and those video links out again through the professional association. There's a question here, I guess, that the tracking of the visits is something that I think is perhaps the most critical issue, the thing we're hearing most commonly. There's a question, who is responsible for tracking those visits? I understand there is an item tracker, but that it's very difficult for an allied health professional to do that. Is there any responsibility for the general practitioner still to, track that and provide that in the referral? I think we have kind of covered that a little bit, but I wouldn't mind if you, Imogen or Alex, perhaps just touched on that again so we can be really specific about that, because I think that is a thing that a lot of people are sort of struggling with at the moment.
Alex, do you want me to jump in?
I was just about to say, do you want to take that one, Imogen?
Yeah, thanks. Okay, so the GP has never technically been responsible for tracking how many services a patient has received. So Medicare benefits are an entitlement for the patient. But at the end of the day, if as a practitioner you are providing a service under the MBS, you should be confident that the patient is eligible for that service when you bill them. So the patient, as I said, you should have their informed financial consent providing a service, and part of that is knowing that they have a plan, they have a referral, the patient is eligible for the service, and the service is consistent with the plan. So we really strongly encourage you to either check AHPs or make sure the patient knows that they have services available before attempting to claim that service through the MBS. Liz, did you want to add to that?
Yeah, I just wanted to clarify and confirm that the GP also doesn't have visibility through any of the Services Australia tools of how many services your patient has had. It would be the same privacy challenge that we would have sharing claiming history with yourselves. So if you think about the patient's journey, they may be seeing multiple allied health professionals and perhaps they're not seeing them daily. Perhaps they're going once every 6 months, and with the reporting requirements, the GP may not be aware of how many services they've had with their physio because they're still going through the number of services that that patient needs to be able to tell the dietitian that, the patient has already had 3 because they haven't actually received those reports back yet. They're still going through that process. So the person who does have the access is the patient. They can see what has been billed on their history, what services that they have received. I understand that can be challenging for some patients. It's also not available for those under the age of 18 as their history is protected due to consent requirements. So, it's about having as best an informed financial consent discussion. Obviously, any services checked through the self-service tools, whether it's the same day, can be affected by subsequent claiming. and a claim could still reject because there are lots of rules that go into determining eligibility. And it's just about providing the best information that you can when you're going to provide that service to the patient. There are other funding mechanisms I'm sure the department could talk about that are available where Medicare benefits are not, including private health insurance and state-based funding arrangements as well to help patients, with their treatment needs.
Thanks, Liz. I guess a related question that sort of came up in a number of different ways was around reporting and was perhaps a similar issue. So, one of the scenarios that was presented was, you're an occupational therapist for argument's sake, and there's a referral and you provide, let's say, 2 sessions, you provide a report on the first. The second ends up being your last session because the patient doesn't come back, but you don't know that that was the last session because they've decided to go to another provider or just to stop providing services. There's really no way you can address that, is that, other than having a discussion with the patient and trying to identify as best you can whether that's expected to be the last service. Yeah. Thanks.
Yeah, absolutely.
Thank you. Look, we have reached time. I'm conscious that we haven't addressed every single question, but as I said, from an AHPA perspective, we will go through both your feedback and your questions, and we'll draw out any that we haven't covered. And the department has kindly offered to try and help answer the questions that they can. Perhaps Services Australia as well. I won't commit you, but we will ask for your assistance as well. So we will endeavour to follow up any questions that we haven't covered today, and we'll work with your associations to get that information out. As I said, we'll also provide some of the links that have been referred to today, some of the education information that is on board, that is available online. So at this point, I would like to just say a massive thank you to the Department and Services Australia teams for coming and talking to us today. And to everyone for participating. Thanks. I know this is a period of transition. I know there are some challenges from an AHPA perspective. As I said, we're certainly working with your associations to understand those challenges, and we do luckily have the mechanism of the review to hopefully provide input and keep tinkering, as well as supporting the education on both the allied health side and the general practitioner side to make sure that we work more seamlessly as we go forward. So, as I said, thank you everyone for participating, and yeah, we'll be in touch.